Good morning. This is Antonio Anzueto for University of Texas in San Antonio. Thank you for joining me this morning. We're going to talk about nebulization in the COVID-19 era, the evidence-based review. This webinar was sponsored by Educational Grant for Theravance Biopharma. This is under the CHEST, American CHEST physicians are the ones who is holding the meeting. And I say I'm a professor of medicine, University of Texas in San Antonio. I'm also a section chief of the South Texas Veteran Healthcare System. I'm not being compensated by Theravance to give this presentation. This was an unrestricted grant to CHEST. So what we'd like to do today is discuss 4 areas. Identify the transmission mechanisms for viral respiratory pathogens. Compare procedures considered as aerosol-generating base. So this is a term that we're going to be using back and forth today, this AGB, aerosol-generating base. So just keep that in mind. It took me a little while to try to figure it out. And we're going to look at the recommendation from national and international scientific societies. What are aerosol-generating procedures and what are the risks for viral transmission? I'm going to examine the available coronavirus data related to nebulization. And I want to finish this with a review of the current recommendations for administering nebulized medications during the COVID-19 pandemic. As you know, nebulized medications are very important therapy for our patients, especially with chronic lung diseases, COPD, asthma in emergency setting. So this is safe to be used. The message at the end of the day is going to be, we try to maintain the appropriate therapy for the treatment for our patients. So let's talk about viral transmission of respiratory pathogens. So this cartoon gives you the 2 main routes of viral transmission. So you have on the left side your infected individual. He probably has fever or not. And remember, there could be a fair amount of people who are asymptomatic, but they are infectious. And it can be this viral transmission to 2 pathways. One is going to be at the upper part of your slide, what is called the droplet nuclei. What it means is these are less than 5 micromoles, they're very small particle size, and it can travel less than 1/3 of a feet or 1 meter, and these are called the aerosolized transmission. In the other hand, as you can see of the next part to the figure who's infected, the droplet size, these are more than 5 micromoles in diameter. This can travel less distance, but this can be like large droplets. This can be transmitted through indirect contact, through direct contact. For example, you shake the hand of the person who just sneezed into his or her hand, or indirect contact. The particles can be deposited on surfaces, and as a consequence, you touch that surface and indirect, you can be affected. I think it's important to emphasize on the right side this notion of susceptible individual. We don't understand why and how. Some people seem to get it, get infected. Some people don't get infected, and the magnitude of the infection varies a lot among the hosts and some of the host characteristics. So basically, it's going to be through aerosolized particles, very small size particles, or droplets that are larger size particles. But there is other factors that you have to take into consideration for the transmission to occur besides the droplet size. For example, environmental conditions. A room that is closed, very stuffy, very humid versus an open doors, open window, the wind is ventilated. A crowding situation. I can see myself being in the security area at the airport and somebody over there is sneezing and is coughing, a very close contact that can increase that transmission. As I said before, host factors and vocal projections. So the vocal projections we have recognized like coughing or sneezing are able to projectile those secretions a little further out. So the virus can infect via the inhalation of the droplets or the aerosols. Also, the aerosols can be in contact with mucous membranes. For example, you happen to have in your hands or the eyes, the person cough, and you can get it through the eyes, or the cough, any other mucous area, has potentially caused a transmission. And of course, a nosocomial transmission can be produced by aerosol-generating procedures. So let's talk about these aerosol-generating procedures. What are those AGP that you're gonna learn with new abbreviations out of this presentation? So this is any medical procedure that is performed on a patient that can induce aerosols of droplet nuclei. So it's more likely can generate higher concentrations of respiratory aerosols. Are going to be coughing, sneezing, talking, even take a deep breath can do that. And these present a risk for opportunistic airborne transmission of pathogens not naturally spread by the airborne route. So there is a potential to place healthcare personnel at increased risk for pathogen exposure of infection, especially if this is inadequate infections control and PPE. And I'm gonna show you some, I think it's really very important data to emphasize the importance of PPEs, of protection for the healthcare personnel. I'm gonna show you some data from the CDC on the first outbreak out in Washington State, where we didn't know what was going on. We didn't know much about the COVID-19 coronavirus and transmission. And unfortunately, the staff that work with those patients did not take in all the appropriate precautions as we do these days. And the other important issue that is important to highlight is neither expert consensus, there are not sufficient supporting data to create a definitive, comprehensive list of AGPs for healthcare settings, and I'm gonna look into that. So let's look first at considerations, these aerosol-generating procedures based on information and publications from the CDC and the World Health Organization. On the right side in your slide, you have the CDC, and this was updated in early August. On the right side is the World Health Organization, and this is the update in June. I'm listing at the top the AGPs, the procedures, and also I'm listing the infectious control of the measurements that should be taken that are recommended by these organizations. And if you can appreciate what is is considered an aerosol-generating procedures can be from anything that's going to be in contact with the patient's airways. Open suctioning of the airways, sputum induction, endotracheal intubation, extubation, coughing after extubation, during non-invasive ventilation, the BiPAP machines, and in mechanical ventilation, turning, tracheostomy, bronchoscopy, and then the administration of nebulized treatment. Within the administration of the nebulized treatment at one point was also put together the high flow oxygen delivery systems. And if you can appreciate here, both the CDC and the World Health, they call it uncertain. They stated that there was enough data to support one way or another, and actually recommended, and initial statements of the CDC strongly recommended to generate data to see if this could be a potential AGP and created a problem. In the bottom of the slide, lists the level of infectious control of PPE recommendations for these aerosol-generating procedures. N95 mask or higher level of respirator, It's recommended to have eye protection. Remember, we talk about the mucosas can be a source, and the eyes could be a source that potentially be infected. Use of gowns, use of gloves, and the negative pressure rooms. At one point in the beginning of the pandemic, everybody thought that was the most that we need to have. But as the course of the pandemic has changed, and also the limitations related to negative flow rooms, we now understand that are recommended, but are probably nothing that is essential. In this slide, what it shows is other scientific societies. What is their recommendation related with aerosol generating procedures? The first column is the American College of Chest Physicians, the AARC, American Thoracic Society, the Infectious Disease Society of America. I have listed the NIH. They have a website that they also have put some information, as well as the Society of Critical Care Medicine. I could have included many others, but pretty much this will give you the sense, the feeling of what are the understanding. And I want you to pay attention is when you see white open spots, there are areas that they don't comment or they don't believe that these procedures can be a risk of generating aerosol generating procedures. For example, chest in the ARC does not consider manual ventilation, ATS does, neither chest, ARC, ATS, or the Infectious Disease Society of America consider putting the patient in prone position. Some respiratory societies consider tracheostomy, others do not consider tracheostomy. And if you look at the high frequency nasal cannula or face mask, there's a lot of open white spots there for several scientific respiratory societies. And both ATS, ARC, and CHEST advise against nebulized treatments where feasible, but they consider that can potentially be aerosol generating procedures. And we're going to talk about this in a minute. At the bottom lays the recommendations for PPE and precaution. You can see it's pretty standard. We all agree what needs to be done to protect our staff and ourselves. So there are several considerations that we should discuss. For example, the CDC Precautions for aerosol generating procedures. So they talk about the individual who's there. So this is very important to emphasize all your staff that's going to be present on any of those to have to wear their mask, have to use your such a disposable filtering face pieces, respirator, and eye protection, gloves, and gowns. Also, it's probably important to minimize the number of people that are in the room, especially if the areas are very close. Certainly, many institutions like ours, we are not allow visitors into the COVID areas. Liability, risk of transmission, the patient is in a room, relative confined environment, so the possibility to have viral in the environment is much higher. Ideally, these procedures, as I said before, should be taken in a negative flow room, and we should try to emphasize the need for clean and disinfect the areas after the procedure is done. There's in many places environmental control, and it's some area that is very important to try to, on a regular basis, clean those rooms and clean that equipment is crucial. So there are internal policies. I imagine each of your institutions have their unique policy, and there is recommendations by the local health departments. But in general, all this goes along the lines of the CDC. So let's go ahead and look at the evidence evaluating coronavirus transmission by nebulization. I have listed here a comparison of selected respiratory virus. On the left side is your SARS-CoV-1. The second is the H1N1, the common influenza A virus. The MERS-CoV virus is the third, and the novel coronavirus or the COVID-19 is the one on the further right. The first column reports the first year that these cases were reported. And if you can see, it was close to 20 years ago that we had the first SARS, and around 10 years ago that we had those major outbreaks of the H1N1. This has allowed us a tremendous amount of opportunity to better understand and better learn, what do those viruses do, their possibility of transmission from contact, droplets, aerosols, and we clearly see that the SARS coronavirus or the novel coronavirus SARS, the COVID-19, does the droplets and aerosols transmission. The basic reproduction number of high contagious this is the lowest the number is less contagious, the higher is more contagious. You can see with the SARS, the COVID-19 is around 3.5, a little less contagious than MERS, but far more contagious than H1N1. There is a lot of discussion about the variability on the incubation period. In this, the novel coronavirus, the SARS, is a little larger, the incubation period. There are reports after 14 days that the individual can have that. And as you are well aware, there is a whole range of symptoms presentation. And this is very common across this respiratory virus. The MERS virus are classically presented very severe, very ill, the individuals who were infected. Something that we are not seeing with the COVID-19. The COVID-19 people that are completely asymptomatic to individuals that can present with very severe. So we have the whole range or spectrum of symptomatology. And also at the bottom of the slide, the fatality rate. Unfortunately, this is something that we're learning every day. The country had a horrible milestone yesterday. Over 300,000 people had died of this virus. So I would say we should not look at what is the fatality rate to my risk for dying or not. One are too many. And our job, it has to be to prevent that one to occur. And should be no more people should be dying of this virus. So there has been some studies to try to understand this transmission of the COVID-19. There is reports of community transmission. These reports came originally from Hong Kong of aerosolized transmission in an apartment building. At one point, there were some concerns that the sewage system could also facilitate that transmission, or the ventilation system could be involved. So there has been several studies looking at the community transmission. The nosocomial transmission, it's very important to remind you that 1/5 of all the COVID cases globally are us, who are healthcare providers. So we should be obsessive, compulsive, and take all the precautions for ourselves and our staff. All our staff must be protected, and we should not, break rules. We should not cut corners to make things easier. We must protect everybody because 1/5 of the cases are too many. I'm going to show you some data that what happens when there is no control by the staff, no protection. And some index cases that were reported in Hong Kong. I'm going to show the index cases for Washington State, where individuals didn't have any appropriate protection. That certainly increases the risk of the transmission. And then we're going to look some data about particle deposition as potential for transmission based on some in vitro as well as in vivo studies. So you look at the risks for aerosol-generated procedures that are done by our staff. And this is a review that in PLOS ONE, that is a systematic review of nosocomial transmissions. Procedures were reported and were calculated the odds of transmission. And this, at the end of the day, increases the risk for prolonged exposure and poor infections control measurements. So that can contribute in a very significant way to nosocomial transmissions. And if you look at the right side in your slide, what are those procedures and what's the risk factor? Very surprising, the high flow oxygen, the risk factor is very low. And it's because the system is contained, it generates very few aerosol procedures. It's much lower than in chest physiotherapy. You can see in this review that nebulized treatments are also very low. It's lower than suctioning. And now we're learning that having a nasal cannula, a 3, 4, 5 liter nasal cannula, generates more aerosolized particles than having a high flow oxygen or do a nebulized treatment in our patient. Bronchoscopy increases, but the highest ones are going to be your ambu bag, your valve bag mask ventilation, the non-invasive ventilation, suction before intubation. So that's an area you have to be very careful. Tracheostomy, coughing to tracheostomy, having tracheostomy, you have a direct open to be able to release the viral. And tracheal intubation is the highest one of the procedures. So we have taken measurements. You saw these pictures of protection boxes during intubation in many places to have the rapid sequencing of paralytics during the intubation can significantly decrease the risk of aerosolization because the patient will not cough. So that lowers that risk in a significant way. So that's something you may want to consider. And also, there are reports that using direct visualization like the Gliscope kind of systems, all those measures together can decrease these risks. These are 3 studies that look at the aerosolization of the potential transmissions of the SARS-CoV-2 or the COVID-19. And let me just go through those because they have a very important information on what do we know. Because everybody's concern is, for how long is in the surface, if the person use any of these procedures, what's the risk to have a lot of particles and virus in the air. The study on your left by Dr. Van Dorpelen, this is an in vitro study. So basically, they generated by the 3-jet collision nebulizer. It's called the golden drum. And so that's why it pushes over there inside this closed surface. And they were able to report that the viral remained viable in the aerosol study for 3 hours. This was in the perfect environment because the drum is contained, is closed, has limited ventilation. So yes, can potentially stay for a while. And this half-life were similar to what we knew about SARS coronavirus 1. So the message of this study is in a closed, contained environment, the viral can remain viable for up to 3 hours. The other 2 studies, they look more in subjects and the possibility of transmission. In the study by Santarpia, they collected air and surface samples of an 11 isolation rooms where 13 mostly mildly symptomatic patients were monitored. The most important is everybody had the appropriate PPE and airborne precautions. 60% of the samples in rooms and 60% of the samples in hallways tested positive for viral RNA in very low concentrations. And this has been an area that continues to be controversial. Maybe at those concentrations and those viral particles are there, can be detected by the technologies that we have, but not necessarily represent that is a viable pathogen that can infect. They were able to replicate the viral in 2 samples in cell cultures out of the 11 samples. And the highest concentrations in patient rooms were found during nasal cannula therapy. So using your high flow nasal cannula is the ones, the regular nasal cannula increases, not the high flow, sorry, the nasal cannula. So if your patient is hypoxic, not that much hypoxic, I will use a Venturi, I will use a non-rebreather mask. You can titrate. The patient is higher, use the high flow oxygen. The study by Lendick also collected samples in isolation rooms with 2 patients, one who was symptomatic. The room was designed as part of the COVID-19 war with efficient filtration, UV irradiation, but did not have negative flow. And 67% of the samples tested positive for the viral RNA and a distance as far out as 6.5 feet. These were very low levels. And again, the comment of before, we don't know if those are viable viral and can potentially give a problem. But all the samples, they were able to culture. So you can argue that they were potential virus, although the concentrations were low, if they culture, could give a transmission. So this gives you the scope of what we know about the potential transmission using aerosolized therapies, and goes back to the point of the importance of protection. Now, this is the study I was mentioned to you before, the morbidity and mortality weekly report of the CDC. These were conducted on 37 healthcare providers who were tested positive for SARS coronavirus 2 and participated in the interviews. Remember, the first case was confirmed on February 27, 2020, and it was the first, one of the first known US cases for community-acquired COVID-19. Here, it was a study. It's appropriate to be done to better understand what therapies can potentially give you a problem, because the staff were not suspecting to have this viral. And as a consequence of that, these healthcare providers did not have N95, did not have any other protection, PPEs, even gloves to do this intervention. And there are 2 of interventions. On the left side is the non-aerosolized generating procedures, interventions that were associated with increased cases of the coronavirus. Remember, there is 3 positive, 34 negatives. The statistics are kind of hard to look at that, but look at the actual numbers. Doing a physical exam, so staying in contact with the individual, taking vital signs, talking to the individual, emptying the bedpan, drawing arterial blood gas, manipulating the oxygen mask. All those interventions were associated with increased risk for transmission. And on the right side, they look at aerosol-generating procedures, and the one who had the highest percentage that was significant was the nebulized treatments, were 2 individuals of 67% versus 9%. But if you look at that list, we also can see that non-invasive ventilation was high, intubation was high, and having any of these procedures also increases the risk. So this was in the setting without having any protection. So that's why that is very important to emphasize the need of the protections. So the rest of transmission, this is a review by the Veterans Administration, is in the website. And the conclusion today is that nebulized treatment may increase the transmission of the coronavirus, but there's minimal evidence that it can produce, cannot be ruled out, but that doesn't mean should not be used in appropriate therapies. Now, I want to show you what happened if you take all your precautions and you cover yourself. And this was, and I showed these studies because these were early when we were understanding the pandemic, when the risk of nosocomial infection was much higher. So over here, everybody had, all the healthcare providers were full PPEs when they do all aerosolized procedures. On the left side are the doctors. On the right side are the nurses. So it's more likely that the doctors, as you can see in the top of your slide, are likely to do procedures like intubation. 37% did less than 10, 12% 10 to 20, you just move forward. The ventilation, I imagine, is bagging the patients, but they did zero aerosol or oral care. So that's important. You go to the right side in the nursing staff. And pay attention is aerosolized inhalation. 35% of the staff never did it, but 60% of the staff did it. And there were 15% that did more than 20. They did a lot of bagging and ventilation. They did a sputum aspiration. And none of the staff who wore full protection, where the protection that were recommended, neither tested positive for nasal swabs or have IgG or IgM antibodies against the novel coronavirus, the COVID-19. So this study emphasized that if your staff is protected, it's safe to use these procedures. And we have to move forward. What's going to be the role of aerosolized procedures in the COVID-19 pandemic? The International Society for Aerosol Medicine is advocating, so we have to develop more interventions to be given via aerosol therapy. And as a matter of fact, there are around 10 nebulized COVID-19 therapies being developed in the US and in the UK. There is a form of nebulized remdesivir that is in clinical trials, as well as the nebulized interferon. I remember this big inflammatory cascade that everybody talks about occurs first within the airway, occurs first in the epithelium in the airway. And if we're going to impact this disease, we have to be local intervention in the airway. So aerosolized delivery is going to be crucial to be able to achieve this. So let's move forward and let's talk about nebulized therapies in the COVID area. Here, I have to learn a little bit of the terminology. So bioaerosol means it's generated by patient during cough, breathing, talking, singing, laughing. Medical aerosol is generated by aerosol drug delivery devices. We can see that, we understand. But the ones that I found very interesting is what is called the fugitive emissions. So these are medical aerosol released from the aerosol device during patient expiration. So just think about that for a minute. The patient has a nebulizer, is supposed to breathe in. With the nebulizer, they use the handheld nebulizer. When the patients breathe out, this is the fugitive emissions. What comes there that is being generated. And that's why there is being argues that to capture that fugitive emissions, we should use some filters. And there is a tremendous amount of development with nebulization. We have these mesh nebulizations that are being developed to be used on patients on the ventilator as well as portable. This study show if the patient has a filter, the face mask without filter is the top. So this is the total aerosol concentration that is generated during the nebulization treatment. And you can appreciate as the colors start getting flattened, going to the bottom, that's when you use a nebulized system with a filter. So different companies, this is the one from Paris, have developed this filter system that can capture those types of aerosol. There are some device-specific considerations at the potential to be aerosol-generating procedures. The jet nebulizers have gone a tremendous transformation, although here it says that the efficiency drug delivery is low. The truth is this has increased in a significant way, who has made it to be very efficient, especially the breath and health nebulizers and the breath actuated nebulizers. As you know, some of those can be portable with a battery operated, so it has completely changed our concept of aerosolization. The mesh nebulizers can also be used. These mesh nebulizers, they're being developed to be used like in the patients on the ventilator. They're being developed to be used as a portable. We do have one as a portable to deliver medication. The MDIs are now HFAs. The problem of those is the log deposition is very low. The dry powders, what the general needs is to have a patient be able to generate a lot of effort, and the slow velocity aerosol, the soft mist, inhalers, this one, the treatment time can be also low, not as low as the dry powder of the HFAs, but this is a slow aerosol generating. And there's the problem with these are very limited medications available in this delivery system, while in the jet nebulizer, we had more variety. And one of the points that we really need to understand is if these devices are generating cough and it's going to make the patient to cough, that won't make any sense. I know at the beginning of the pandemic, we were told no more nebulized medications in the hospital. Let's switch to HFAs. Let's switch to powder form. But the problem was there is a significant increased risk of coughing and to bring it a cough. In some preparations, we do it a purpose of, for example, in the albuterol solution and in the saline, we want the patient to cough to bring up the secretions. But a lot of the MDIs, SMIs, and DPIs, we don't want that to cough. So they will generate cough, and by the end, they're not going to get the medication in the lungs, and they're going to produce more aerosolization. And there are now several studies that have looked at the importance and the economical impact that could have in your institution using nebulized therapies. And now we have a nebulized therapist given once or twice a day. So the first rule and the understanding is albuterol and ipratropium should be used as a rescue medication only. And ideally, you would like to, and you don't want to give it every 4 to 6 hours. And having medications that you can give once or twice a day, this will nebulize, this will make your staff only have to do it once. And that's what your slide on the right side is showing. The green in the graph in the left side is the cost of using albuterol on ipratropium combined or separate on a scheduled basis. On the right side is when you use a once-a-day nebulize. And if you can see the significant reducing costs, not only from the financial point of view, but also the reduce in the need from PPEs, gloves, N95, simple masks, all that can be significantly reduced. In our institution, we have what's called a COVID area. So everybody in that area is patient. All the patients do have COVID, and the staff only have to dress once and to get into that area. And that has significantly reduced the number of PPEs that we have to use. We use gel to get in and outside the rooms. This very significantly facilitates also patient care. So it allowed nursing staff, respiratory therapists to enter and can give nebulized therapy without any concern. We are now changing our understanding of how to use nebulized therapy. The GOLD initiative, I'm a member of the scientific committee. We published a couple of weeks ago a position statement that we emphasize that patients with chronic lung diseases, asthma, COPD, they must continue their appropriate therapy. And their appropriate therapy should include the delivery system. So we now understand that patients who have very low peak flows that are more severe ill, they cannot use those powder forms or some of the HFA forms. Any cognitive impairment, dexterity, but the other is the inability, to hold the breath, to take those deep breaths. And having available nebulized medications pretty much in the same characteristics that the other forms. So having long-active anticholinergic, long-active beta-2 agonists, inhaled corticosteroids gives the tremendous opportunity to broaden our patient care and give them the appropriate treatments. And this slide just pretty much makes some of the emphasis on nebulized therapies. Just pay attention to these fugitive aerosol emissions, especially with face masks, the importance to educate. I tell my patients in their home although most of my patients have been in quarantine, hasn't gone anywhere. They'll use your nebulized treatments in an open area in the living room. You can go to the patio, get over there your medications. Within the institutions, we give the nebulized therapies and we try to get all the staff use the PPE protection. There's still significant gaps. And this is at August 31st, if I were able to put the slides together, but it has not changed that much. There are limited clinical studies on COVID-19. We need to see more. There is a lack of information, risk with nebulization. So we need to have more benchmark studies as well as clinical studies. The viral particles at different distance with the COVID, with the handheld versus nebulizers, different type of nebulizers, and between various forms, the aerosol-generating procedures. But very important, the need for PPEs and airborne precautions should be a must. So to finish, let me have a question for you. And the question is, what are your views on using nebulized medications during the COVID-19 pandemic? Avoid in all patients regardless of COVID-19 status. Only use in non-COVID-19 patients. Continue to use in appropriate patients with recommended precautions and PPE, such as negative flow room, N95, etc. You can vote over there. It's shown in the front of your computer. Here, hosts and panelists cannot vote, so don't worry. I'm not going to bias the opinion. I'm not going to vote. We'll give you a few seconds if you can vote. Yes, so we are seeing the results. And I see here that 86% of you say continue to use appropriate patients with recommended precautions. I think this is the most. I think the concept of avoid all patients regardless of COVID status, that is wrong, as well only use in non-COVID patients. Our COVID patients have chronic lung diseases. Our COVID patients have limitations on how can they use their delivery systems and the medications. And remember, we don't give these therapies the appropriate way, we're going to be in trouble. And I will tell you, at the beginning of the pandemic, when we had the patients on the ventilator, we went back to look at the literature, how many puffs we have to give of the CDC devices, CFC devices, and need to pump into the tubing in the system. But the first problem is a lot of that data were generated with chlorofluoride delivery system, not with HFAs. And there is no data with HFAs. And so we say, okay, let's put 6, let's put 8 puffs. And so we were using far more medication than we needed. We didn't know the patient was getting. And guess what? Our patient was not getting better. So that's what we said, this doesn't make any sense. We have a closed ICU, we have a closed environment. We're going to go back and use our nebulized delivery systems for our patients on the ventilator. And then we start seeing a significant difference. We start seeing significant decrease of mucus plugs, significant, that was described at the beginning. We were using nebulization, humidification in our ventilator circuits. And all that has significant impact on patient care. So at the end of the day, I think it's very important to emphasize that what we have learned in this pandemic, although there is a tremendous amount of concerns that as we as a healthcare provider, and 1/5 of us can be infected, I think we need to follow 2 rules. Rule number 1, we must protect ourselves and our staff, as we did on day number 1. This is here, still with us in our environment, in our hospital. The increased contact with these patients put us at increased risk, so we must protect ourselves. But I think rule number 2 is we should continue practice medicine that we have learned in the last 10 years. The interventions, the therapies, and this applies for nebulized medication. This applies for ventilator settings on patients on the ventilator. This applies for the use of antibiotic sedation. Everything that we have learned, that's the best that we have. we should apply that to our patients. This is not the time to begin to experiment and to try to, oh, let's try this or let's try that. Our patients are too sick. Our patients deserve the best that we have learned of the last 20 years of critical care, the management of very severe lung injury. This is now when we need to apply this. I'm going to stop now. I appreciate your time. And if you have any questions, any comments, I will be very happy to address. Thank you very much. So, question, I'm not going to read the numbers. I don't want to offend anybody. But the question is, what would be the recommendation for a bronchiectasis patient using an OPP device or hypertonic saline by nebulizer in a retirement community or long-term care setting? My recommendation is do it. Don't think twice to do it. Now, let's prepare the appropriate environment. Probably in a retirement community, most of my patients in retirement communities, they had been in their homes, they had been in a contained situation. So that in a contained area, they have limited contact with other individuals who are there. So I will recommend you, let's continue doing the therapies. It's winter time, they're not maybe able to go out. They try to do it in the larger room that they have, but you have to continue doing that. As a question, can I get a copy of my slides? I think that Mrs. Rodriguez will answer this question live. She's here online.
Good morning, everyone. And we've recorded this webinar, so that will be available hopefully by early next week. Slides, I'm not sure, but you will be able to receive the recording.
Thank you. Thank you, Lily. There's a very good question. Do you use hypertonic saline 7% nebulized and mucolytic? Yes, I do use 7%, but let me tell you, I have patients who tell me it's too much, irritates my airway. If my patient start having some hemoptysis, start coughing up a little bit of blood, irritates too much. In some patients, I need to use 5%. In some patients, I need to use 3%. At the end of the day, anything that you use is better than nothing. So I think you should try to titrate the amount to the what is the patient's needs at that particular time. There is in the chat room, there's a question here. I work in a free safety net clinic. I do a lot of asthma and COPD, but many walk-in come in wheezing and shortness of breath. We don't have MDIs or DPIs, but I'm using HEPA filters, air filtration, and high-level PPE. You're doing the right intervention. The right intervention is, yes, first, remember, rule number 1, you're protecting yourself. So rule number 2, you may want to use the nebulized medications. You can add the HEPA filter to the exhalation port to try to capture that expiratory virus. Those individuals, very likely you're going to be testing them for COVID, but my advice is consider COVID positive until you prove something else. On December the 15th, 2020, is not what we used to do in May 2020. Oh, this is a PUI, we're suspecting him here, oh, I'm not sure. No, this person is a positive until you prove that it's not. So what you're doing, sir or lady, sir, I think you're doing the right thing. There is another comment here. So available slides online, and told me Rodriguez already explained that this is going to be available, and the recording, you all can have access to that. And a person here just agree with universal precautions to everybody, and I think this is probably the best way to handle these days, to go and using as much as you consider the patient is positive. There is a question here. Is there a timing to do a percutaneous trach that you use? More than 10 days, early, how do you time? Year apnea, years under ventilator. Thank you. Okay. So the first question about doing tracheostomy. Overall, we talk about, 10 days to 2 weeks is the time we should consider. But at the end of the day, the point there, I think, is you're walking in the forest. And this, I found this sometimes to be very, very hard to put a time when to do the trach, because today patient looks bad. It's been 10 days on the ventilator. You say, no, she's not gonna be able to extubate. But tomorrow you were able to lower the FiO2. It was more awake. Everybody's very encouraged that, it's getting better. Well, let's wait. We're not gonna do it today. Let's wait another couple of days. But then 2 days later it got worse. I try to do as a rule, I try not to get these patients, especially with bilateral diffuse lung injury, being on the ventilator. I tried not to do it past 2 weeks. So anytime between day 10 and day 14 is what I strongly consider the tracheostomy. What are your views on bedside spirometry? So the bedside spirometry, your patient you already know is COVID negative, so that is a wash. You already know it's COVID negative. You don't have to worry about that. If an inpatient is COVID negative. Let's see, let's do a bedside spirometry in the patient who is COVID positive. If you work in a contained area like we do, everybody has PPEs, the patient, the equipment, everything is contaminated. So we do have a spirometry to do there. I think it's very important to do bedside spirometry because you and we all see all these patients that are labeled as COPD and they have never had a spirometry. How do you know they have COPD? And many times, what I do is I go and we do a bedside spirometry and that ratio is 90. And the reason this individual is short of breath, this individual is coming back and forth, is not because they have a fixed obstruction like COPD. They have interstitial lung disease, restricted lung disease, is their heart failure. And your interventions and the treatments have to be different. So if you have a question about diagnosis, my advice, do the bedside spirometry. Try to answer the question if my patient has a fixed obstruction or not. What type of anesthesia would you recommend before doing bronchoscopy in COVID era? Patients who are, so bronchoscopy in two settings. Patients who are severely ill on the ventilator, the sedation that you use. In our institution, we had maintained our intervention team active during the whole pandemic. Because we know, especially my work at the Veterans Administration, if I find an individual with a 3-centimeter nodule that is speculated, I don't have the luxury to wait 6-9 months or a year to try to make a diagnosis and to give him or her an appropriate therapy. So we have, since day number one of the pandemic, very active doing diagnostic procedures in our patients, especially lung masses of any other abnormalities. And we do two things. First, we test for COVID every single of those patients that morning of the procedure. So we, as sure as much as we can be sure that they are COVID negative. We use full PPEs on those patients. And we try to use, when we're using more and more anesthesia for airway management and airway control, because that can potentially decrease aerosolization. If there is a procedure doesn't need to have anesthesia, we use the moderate sedation and the conscious sedation. But the premise here, we use in full PPE, and that individual was tested. So do you recommend to use PPE protection even in nebulized patients PCR negative in view of possibility of fail negative test? Yes. Use full PPE, full B, you use your N95, you use a face shield or goggles, and you use a disposable gowns and gloves. With that, you are protected, and but you should do it. Because, we even have people that initially came negative and can become nosocomial infected. So err on the side of doing more precautions. Should we use same precautions for COVID with flu and any other airborne carrier disease? That's a pretty good question. One issue that has happening is we're seeing a significant decrease of flu. This was first reported in New Zealand, Australia, when they had their winter during our summer. And we are seeing now the face mask people are using, or even non-using, they're being protected. But it's probably more important the kids are not going to be going to school. I can tell you my grandchildren, they were going to school in August, October. Now they're not going to school anymore because they closed the schools. They were told by their parents, you have to wear this mask, you don't move it from your face. And they did not move it from their face. And they came home with the mask and they kept it all the time. So the population who has the highest risk for transmission, that are children, is being contained. And that's why we have seen a significant reduction in flu in this. And to answer your question, yes, we should use the same precautions, although there have been very, very low reports also of a coexistence of flu and COVID-19. There's a question here. You mentioned the routine Q4 albuterol treatments. Do you see any benefit for routine tiotropium bromide or ipratropium bromide next Q4 with albuterol? Okay. The principle here, what we have learned in the last, I would say, 12 years, is more is not better. So give nebulized albuterol every 4 hours, you're not getting better to the patient. As a matter of fact, you make the patient worse. You should use the short-acting bronchodilators, ipratropium and albuterol, as a rescue only, if the patient wheezes. But at the same token, if the patient has COPD, asthma, use their maintenance therapy as soon as possible. So you want to restart the long-active anticholinergics, either with SMI system like tiotropium or nebulized with the different forms that we have nebulized. You want to restart the long-acting bronchodilator, the inhaled corticosteroid. You want to restart the maintenance treatment as soon as possible in order that you don't have to use the rescue medication on schedule. In our institution, we don't give it on schedule. We use it at PRN in all the patients. A question about what are your thoughts about reusing N95 masks? You know, I can tell you, I reuse my N95 mask. At the beginning, we're supposed to use it for 24 hours, send it to somewhere, they will sterilize, bring it back to you. But I think over time, what we have done and we're doing is if I'm with a COVID patient and I have to use an N95, I use the N95 and I use a disposable surgical mask on top of that. So after I leave the room, I toss the surgical mask, the N95, I clean it, and I wear my other mask, this one. So I save my N95s for my COVID patients or I enter the room. I think this has to be your institutional policies, and I know more and more institutions are allowed the reuse of the N95. Well, listen, it's 11 o'clock Central Time. I really appreciate all your questions. I really appreciate your time, and you're making a difference. You're making a difference every single day, and keep doing it. But please protect yourself and protect your family, because we need you. Your institutions need you, and we need you healthy. We don't need you sick. So please protect yourself, your family, keep doing a good job that you're doing. We're getting get to the end of this all together. You all take care. Have a happy holidays. See you later.